All right, good deal. So today we're going to talk a little bit about a couple common anesthesia medications. And one of the biggest areas students have trouble with when they get to clinicals is medications, and particularly dosing and indications, contraindications. This is one of the things we've tried to kind of drive into you as the program's gone on to make sure you understand them. But I can't iterate how important it is that you get to clinical and you have to know these medications inside and out. So we're going to review some of those, but take those pocket cards with you. When you're doing your anesthetic plan, make sure you know exactly what you're going to give, the dosage for that patient, and kind of how to alter that plan if need be. So, we could take forever to go over this. We're only going to go over some common ones today. But if you look at those cards, there's a lot of different information on there. Make sure, particularly like if you're going to do OB, you've got all your OB medications kind of fresh in your mind, and that sort of thing. Because what you're going to see is if you don't know it, you're going to get to clinicals, and they're going to form a quick opinion about you. In some places, they're going to tell you can go sit down someplace else, or you can stand there and watch until you figure out what you need to be doing. And you don't want that to happen to you. So, big thing for you to remember for your anesthetic gases is going to be your different MAC values. Depending on what text you read, you'll see there's a little bit of variation as far as what the MAC values are. But commonly accepted ones are important to know. So generally, isoflurane is going to be 1 to 1.1. Sevoflurane is going to be 1.8 to 2. And DES is going to be about 6 to 6.6. So make sure you're familiar with those. Also make sure you know how the addition of nitrous oxide will affect those. A lot of times you'll use nitrous oxide during the whole case, and you may also use it as kind of a wake-up to turn your volatile agents down. So, as I mentioned, make sure you're familiar with the gases. Also be familiar with why you would use different agents. Part of it will be a cultural thing. Some places you go and they just use isoflurane because it's generally inexpensive. Other places you may use nothing but sevoflurane or DES. If you're doing an inhalation induction, especially on a pediatric patient, you want to try and use sevoflurane because it's not quite as irritating to the airway. Desflurane is pretty beneficial if you're doing short cases and you want a quicker wake up. But if you use the other gases, you kind of figure out how to manage things so it's not really a long wake up either. One thing you have to be very cautious with DES is it's expensive. So if you're using a lot of it, somebody may come say something to you. That's part of the reason a lot of places have gone back to isoflurane and Sevo, just because they are less expensive. Money is always going to come into play for things. Other things to think about, make sure you know the cardiovascular effects of each of the medications, because it's kind of important. And the other part of that is you're going to have people in their personal biases that come into play. For instance, if you work with me, I almost exclusively use ISO. And I can justify why. You work with somebody else and they may exclusively use Sevo, and they can tell you why they do that. So try and, as you guys get to clinical sites, figure out the different nuances for providers and share them with your classmates. So that way they are aware and kind of learn through your mistakes, if you will. So this is kind of the quick and simple things to remember about them. As I said, DES is kind of irritating. It stinks. They all stink for that matter. You will see some heart rate increase. And as I mentioned, it's very low solubility. So it's good for obese patients. So it's fast on, fast off. And remember, it's got to have a special vaporizer. So you're going to have a power cord too. You will see people that will come into rooms because they're insistent they have to use DES, and if you have the DES vaporizer, hopefully they'll ask. If not, they may just take it. So if you need one, make sure you've got it locked down somewhere. Subo, we use a lot of times, as I said, because it's not irritating to the airway, so we may use it for inhalation inductions. It's not the most expensive, but it's more expensive than isoflurane. It does tend to stick around a little bit longer in obese patients, especially than DES. Isoflurane, it depends on where you go. As I said, some places they don't use it at all. Some places they use it for everything. If you go to Shreveport, they use a lot of ISO. I used a lot of JPS. So just figure out what the common gas is. What you'll figure out is, one, anybody that's staying on a ventilator is probably going to get ISO because it's less expensive, because you're not worried about them coming off. But the other thing to think about is that if you start planning out your emergence correctly, it really doesn't matter what medication or what gas you're using because you can time your wake up. As I said, a lot of times we'll use nitrous in conjunction with something else. So you may have them doing like a TIVA, but you're also running some nitrous, or you may be using nitrous along with your volatile agent to reduce your MAC. So things to think about that influence anesthetic requirements. Generally, increasing is going to be chronic alcohol abuse. Infant, remember your highest MAC is going to be at 6 months. Traditionally, redheads are a little more problematic, and then patients that are hyperthermic because of the hypermetabolic state and hypernatremic tend to also have increased anesthetic requirements. Decreased anesthetic requirements are generally associated with the acute alcohol use, elderly patients, hypothermia, hyponatremia, anemia, hypercarbia, hypoxia, and pregnancy. The thing to remember for a lot of those patients is they may already be somewhat sedate to start off with. So why do we use the gases? The big thing is the speed of onset. So when you start looking at whether you're going to do a TIVA or a traditional general anesthetic for patients, you've got to figure out the length of the case, how fast you need things to be done. Because generally, if you're doing a TIVA, you're going to have to give a bolus of a medication followed by an infusion. Whereas with the volatile agents, you can start off with just agent alone. You don't necessarily have to give anything IV. Indeed, like if we're doing an inhalation induction, you may just give inhalational medications and they may never get anything IV. The other nice thing about it is it's one of the things you can give and take away. So if I have somebody that's, the pressure is high, it looks like they're a little bit light, I can increase my volatile agents, but maybe the pressure comes down, I can take the gas away, just turn it down, blow some of it off. And that's kind of a nice thing. A lot of our IV medications, there's no taking it back. There's kind of a potent therapeutic window, so you have to figure out what that is for your patients. Some patients are a little more generous than others, and some are also a little more forgiving than others. So kind of went over all that sort of stuff. Big thing is know your differences, know when you're going to use one gas versus another. Other thing to keep in mind is we still don't really entirely know how they work. This provider preference is a big part of it. Depending on who you work with, this may be the right medication, the wrong medication for anything, including your volatile anesthetics. And generally for pediatric patients, it's going to be sevoflurane for everything. All right, so propofol is something you guys should be pretty familiar with. Things for you to think about here is not only your dosage for induction, but also how it's supplied. Generally, what you're going to see is it's coming 10 milligrams per ml in a 20 ml vial. Induction is usually 2 milligrams per kilogram. And you'll see that we use it for a lot of different things. You may be doing a MAC or a sedation case, and you'll run an infusion of it. You may also be in a TIVA case where you're not using any gas and run an infusion of that as well. Problems you run into with propofol, it depends on where you go. Some places it is a controlled substance, but most states don't actually define it. Because of abuse potential, they generally will track it down. It does burn a little bit with IV pushes, so a lot of times you're giving lidocaine up front. If you're giving it through a central line or somebody that's already sedated, it's not usually an issue. In elderly patients, be ready to decrease your dosage. The problem you run into is there's not really a great formula to figure out how you're going to decrease it. Just know that it's probably going to have to go down some. The other thing you may see is that a lot of times propofol is mixed with something else, ketamine, for instance, or etomidate. So I may give a half dose of propofol and a half dose of etomidate to have a little bit more cardiovascular stability for patients. So nice things about propofol, it induces unconsciousness pretty quickly, generally about 30 seconds, and it goes away pretty quickly. The exception to that is if you have somebody that you're using it for a long time, think about an ICU case or maybe a TIVA where you're running high doses, that 150, 200 mics per kilo per minute. A lot of times it takes some time for the patient to wake up from that. So you've got to make sure you turn it off a little bit early. If you've got somebody that, you want to wake up. If it's somebody going back to the ICU, it shouldn't be a problem. All right, just looking through questions real quick. Why ISO? One of the nice things about ISO is that a lot of times you will get deeper sedation at a lower MAC. So as opposed to where you have to use a full MAC of SIVO or DES to get the adequate MAC, you'll find that with ISO, a lot of times you can do it with a half to 2/3 of the general requirements. The other nice thing is because it does stick around a little bit longer, you tend to have a little bit smoother transfer to emergence and extubation because the patient's still a little bit deeper. But with them still being a little bit deeper, you don't generally have the same problems you do with sevoflurane, with laryngospasm, and that sort of thing. All right. Other things to think about propofol, it is a bronchodilator. And one of the big things, and one of the big reasons we use it, is that you get a nice sympathetic blockade when you administer it. So before I stick a nice cold laryngoscope in somebody's mouth, it's good to have it. The downside of that is that it also causes a sympathetic blockade to the rest of the body. So you do tend to get hypotension. Some cases you may see bradycardia. Another thing, it's probably the most potent antiemetic that we have. So if you have somebody that is vomiting or nauseated, generally a cc or 2 is enough to stave that off while your other medications work. So when you finish a case, always take the propofol to the recovery room with you. That way, if they become nauseated, you can administer it. So sometimes we will run into some issues with it. One of the biggest things is that the patients on long-term infusions, usually in the ICU, it's not an OR problem, will start to develop propofol infusion syndrome. So lipids will go up. It's obviously a very fatty medication that's diluted in lipids. You'll start to see infiltrates of the liver may get large. You may see some rhabdo, and finally you may also see myoglobinuria. So when you start looking at things, they tend to develop kind of this. It's not necessarily the traditional myoglobinuria we think of. A lot of times you'll see kind of green urine. So if you start seeing that on somebody that's on propofol for a long time, consider that that's a possibility. The other thing you have to think about, and you'll see this when you go to the ICU to pick up patients, is we spend a whole lot of time fighting ourselves. So you'll have somebody that maybe their blood pressure was a little labile. They put them on propofol for sedation, and now their blood pressure is low. So now you've got to put them on a vasopressor to try and bring their blood pressure up. So, if you are in a situation where you're maybe acting as an intensivist or helping out with sedation stuff, look at the big picture. Maybe I can use some propofol, but mix it with fentanyl, Versed, ketamine, something else that's not quite as drastically going to affect my blood pressure. All right, moving on to etomidate. I don't use a whole lot of etomidate, but generally if I do, it's going to be somebody that's got a sick heart. The traditional dosage is 0.3 milligrams per kilogram. You may see a little bit of variability there, 0.25 to 0.35, but 0.3 is a number to remember for this. As I said, most commonly it's going to be used for sick hearts. You will see it used in other unstable patients, trauma, the elderly, and sometimes again provider preference comes into play here. Generally, if I have somebody that's sick, I will go with a ketamine or a ketamine propofol mix. Other places they go with etomidate for almost everything. There are some known issues with etomidate. It does cause adrenal suppression. But one of the big things is that it's kind of conflicting literature as far as how much and what the impact of it is. But with that being said, if you're seeing some sort of adrenal suppression, it may be something to avoid if you have a choice for somebody that's already sick. Other thing, it's one of the highest rates of PONV among our induction agents. So if you have somebody that's high risk for PONV, propofol that's also might be a better choice than something that is known to cause nausea. Other things you'll see with etomidate, it does burn, and it also will cause myoclonus and potentially seizures. So if you have somebody that's got a seizure history or you're concerned about an airway, it may not be your best choice either. Ketamine, things to remember, it is not a hypnotic agent. It just causes dissociation, and it's dose dependent. As we talked about with analgesia, if you use very low doses, generally it will cause pain relief. So it's not uncommon to mix that with other medications as part of a multimodal package. So generally at that dose range, you'll start doing, 0.2 to 0.5 milligrams per kilogram. As far as induction, if you're giving it IV, you have to look at your patient. If you have somebody that's extremely sick and you're just trying to make sure they don't remember things, you may consider starting at that 0.5 milligrams per kilogram and working your way up to 1 to 1.5. And it just kind of depends on your center as far as what they do. Other things, you will hear people talk about ketamine darts. You will mix ketamine with Versed and Robenal. And I had Catch the Kid, but it may not be a kid. I chase down just as many adults as I have kids. The nice thing with that is you give it, and they get pretty quickly sleepy, which is better than fighting. I'm too old for that. Other things for you to think about that because of the ketamine, it will increase your adrenal activity. So try and avoid MAOIs. You will also see that as far as ketamine, you get a variety of concentrations. Some places will do pre-mixed where you may just have a 10 milligram per ml or a 20 milligram per ml syringe. Otherwise, it's pretty common to see it either in 50 milligrams per ml or 100 milligrams per ml. And then people generally dilute it to their own desire. Usually if I dilute mine, I do it to 10 milligrams per ml. Other things with ketamine, the delirium is kind of the biggest side effect we worry about, but it's not very common if you do small doses. Even with the induction dose, if you don't redose it, a lot of times you're okay. The only time I've had it was when I gave a substantial amount over several hours. Nice things that come out of it, it increases your SVR and PVR, your heart rate, your cardiac output. So if you have somebody that's already hypotensive, it may be beneficial to give them that. Other things, if you have somebody that's got reactive airway or is asthmatic, it's not uncommon to give them ketamine because it is a bronchodilator. The one downside you'll see with that is a lot of times it increases secretions. So you may have to pre-treat them with Robenal. Generally, if I do it, I go ahead and pre-treat them with Benadryl so they get a little sedation as well. Likewise, if I'm doing a MAC case, I will usually give them some low-dose Benadryl. I'm talking about like 6.25 or 12.5 milligrams up front. That way, they get some sedation from it, and if I need to give them ketamine, they're already dry. Other things to think about, they maintain their airway tone. So even though their airway is not necessarily protected, you may find that they maintain that airway a little bit better, so you don't have the same problems with relaxation that you see with propofol. So if you have somebody that winds up having like a post-ketamine delirium, a lot of times we'll just give them a benzodiazepine, Versed, something like that. But it kind of varies on the patient. You may also be able to give them just a little bit of propofol, and they'll be sedate. When they wake back up, they're okay. But the caveat to that is that a lot of times the reason we were using ketamine anyways is because they couldn't tolerate some barbiturates or propofol. I threw dexmedetomidine in here. It's not really a true induction agent, but you'll see that it gets used in a wide variety of purposes. It may be used as an adjunct for induction, or you may have somebody that's coming down and they're just getting sedation with Precedex. So things to keep in mind for the patients, the biggest things we worry about, because of its alpha blockade, you tend to have some sedation, which is generally what we want. You may have, depending on what's going on in the dose that's administered, they will almost always be bradycardic. So if you have somebody with cardiac issues, it may not be a good choice for that patient. It's also not uncommon with that bradycardia that they have some hypotension. So just look at your patient and think about it. The nice thing for us is a lot of times you can use Precedex to kind of smooth your emergence and also reduce your opioid requirements. So even with very low doses, you can get kind of the effects we're looking for. The dosing regimen varies greatly from one place to another. Some places will tell you to do like 0.3 to 0.5 micrograms per kilogram as a bolus. But bolus is kind of a relative term. Even if you do it, you're still going to do it very slowly. And it's kind of weird. You may have a rebound hypertension if you give it too fast. I generally use a significantly reduced dosage from here. The other thing you'll see is a lot of times you have to mix your own Precedex. So the standard concentration is going to be 4 micrograms per ml, and it depends on where you go how it's supplied. Some places will give it to you in a bag. Other places will give you 2 ml vials, and you have to mix your own. So just make sure you're familiar with what your facility has. Other things we have to worry about with Precedex, you do have some respiratory depression, but it's not as significant as some of the other medications that we deal with. As far as comparing it to the rest of the induction medications, it's substantially lower. It does tend to cause some drying effects, so if you're going to give somebody ketamine, it may be beneficial. If you have somebody that's obese, you may want to think twice about ketamine because they tend to relax their airway reflexes just a little bit. Or, if they're already prone to sleep apnea, something like that. It may be something you want a little bit more awake as opposed to the sleepiness that tends to accompany Precedex for a long time. Other nice things for us, it will a lot of times tends to block any sort of shivering reflex. So, if you have somebody that's shivering post-operatively, some Precedex may be helpful. Other times we'll just use Demerol for those patients. If you give it, it may prevent the muscle rigidity that's sometimes seen with high opioids, but a lot of times we're giving a muscle relaxant anyway, so you don't have to worry about it quite as much. Patients that are going into withdrawal tend to do very well with Precedex. You will see that patients that do have withdrawal, and generally when I'm talking about, I mean alcohol withdrawal, are pretty high risk for anesthesia and anything else in the hospital. So anything we can do to kind of block those effects is pretty beneficial. The other thing you will see is that chronic pain patients tend to do very well with Precedex as well, just because their receptors are so fried that a different approach may be beneficial for them. You may go someplace where they use Brevitol or methotrexate. Personally, I've only used it a couple times, and when I was doing it, it was for ECTs. Your adult dosage is 1.5 milligrams per kilogram. The nice thing is it's generally a pretty fast on, fast off medication. Things you will see that are problematic, it may cause myoclonus and hiccups even at low doses. You may also see seizure activity at low doses, which is generally not a problem because when we're doing ECTs, we're almost inducing seizures. The funny part of that is that you'll see it's used to treat seizures at high doses. Other issues you run into for these patients, they can have airway irritability is because of it's not quite the deep sedation that you get with the medications. It's more of an amnestic agent. So the biggest time you're going to use this, and there are exceptions, is going to be for ECTs because any other medication we give for the most part is going to depress the seizure somewhat, whereas the methotrexate does not. Some places they will use it for cardioversion. And then other places, if you're trying to map where the seizure is actually originating from, you may see that they give methotrexate for that. It's not very common. I think there's better agents out there. But you never know when we're going to have a medication shortage or you're going to go someplace and, they use different medications. So you need to be familiar with everything. Let's see if we have any questions real quick. Jacob was asking why Robenol with the ketamine doesn't it already cause tachycardia. Yeah, we're giving it for the secretion, so it's just a drying agent. Hannah asked what vitamin B is. That's Valium or Versed. Yeah, as Indigo said, it just depends on what your choice is. We don't use Valium quite as often as we did in the past, but it's kind of like Brevitol. You may go someplace and they use a lot of it. All right, moving on to our opioids. Kind of the basic everything else is compared to morphine. You will go some places where they use morphine for everything. You will go some places where they tell you morphine's the devil and you shouldn't use it for anything. So just be familiar with the practice wherever you go. As far as the dosing goes, generally it's going to be 2 to 10 milligrams. You may see that if you've got somebody that's got a high tolerance, they increase it to 20 milligrams. It's going to be kind of delivered in incremental doses, though. So pick whatever number makes you happy. I usually do even numbers, so I'll do like 4 and then 4 more. You can always give more medication, but you can't take it away. One of the biggest problems we run into with morphine and all the opioids for that matter is the respiratory depression. So you have to be very cautious in somebody that's maybe not breathing that well already. And think about other medications you can give them that will reduce their pain level, but may not reduce their respiratory effort. You will also see a dose-dependent histamine release. So as your dose goes up, the histamine release goes up. So if you have somebody that's already hypotensive, it may be problematic for you. A lot of times you don't see that with fentanyl, which is one of the bigger reasons we give that. You will see that it decreases your peripheral vascular resistance with high doses, again, because of that histamine release. And then the other thing you have to worry about is the active metabolites, which are prolonged in patients that are elderly, liver failure, or for some reason they're not clearing things quite as well as they should be. Dilaudid, same thing as morphine. Some places use lots of Dilaudid, other places they don't use any. The big thing for you to remember is it's significantly more potent than morphine, but you don't have that histamine release, so you generally don't have the hypotension that you see with the morphine. It's a much longer acting agent, so when you start thinking about things as far as duration of action, very short is going to be remifentanil. After that, sufentanil, then fentanyl itself, followed by morphine, and then ultimately Dilaudid is on the higher end. And you may go someplace where they do IV methadone as well for pain, and that's obviously a substantially longer duration of action than the others. As far as your Dilaudid dosing, it's generally going to be 0.5 to 2 milligrams. Again, titrated in. It's not uncommon to give a half or a milligram, wait 10, 15 minutes, see how the patient's doing. The thing you have to keep in mind is that because it has a little bit longer onset, you may need to wait a minute before you give more. Otherwise, the patient may wind up with a higher dose than you intended. So just something for you to think about. The other thing is when you start looking at what PACU orders you're going to write for patients, be familiar with kind of the practice there. Some places they'll use Dilaudid for everything. They may use significantly lower doses than we do. It's not uncommon for them to administer like 0.2 or 0.1 milligrams at a time and see how the patient does and go from there. Fentanyl is a synthetic agonist. Your dosage for this is generally going to be 1 to 2 mics per kilogram early on in the case. There are some places where they do fentanyl infusions. Generally, if you do, it's in combination with Versed or a benzodiazepine. It will cause respiratory depression. You will see that I think it's going out of favor now, but some places they use fentanyl as the induction agent for cardiac surgeries. So you may have a patient that's getting 5 to 10 mics per kilo as their induction agent. If you have somebody that's elderly, consider decreasing it. Same thing, obesity, consider decreasing it because of the concern for respiratory depression. Fentanyl, we generally dose on ideal body weight, but you can make an argument for pretty much anything to go back and forth between actual and ideal body weight. And it's going to be our biggest agent we use, so make sure you're familiar with the dosing for certain for your fentanyl. The other thing is it's supplied in a whole lot of different ways. You may get fentanyl that comes 100 micrograms in 2 mLs. You may see 250 micrograms in 5 mLs. And then they actually have vials out there that have like a milligram of fentanyl in it. So make sure you know what your supply is. And when you start thinking about your case in the morning, get what you need. A lot of times it's hard to get additional medications, so it's not uncommon that we pull a little bit extra to cover us. I kind of touched on Demerol a little bit earlier. The biggest thing we're using Demerol for right now is postoperative shivering. You will see some places, especially in pediatric patients, that they use it for analgesia, but it's not very common. One of the big reasons is that it's not a very good pain medication. It causes sedation and they get a high, but as far as the actual pain, it doesn't seem to do much with it. Other things you have to worry about is that it can predispose you to seizures, especially if you already have a seizure history. It's contraindicated with MAOIs because of the blocked reuptake of serotonin. So as I said, the biggest thing you're going to use it for is shivering or shaking post-procedure. Sufentanil is a kind of faster duration of action IV opioid we use. Dosing is going to be 0.5 to 1 micrograms per kilogram. You will see some places they use sufentanil as their induction. They may not use fentanyl at all. The problem you run into is if you haven't done a good job of covering their analgesia a little bit longer or like headed into PACU, they will have pain. So some people will run like sufentanil infusions for cardiac stability or keeping the patient comfortable the whole case. And then towards the back end, they'll work in some Dilaudid or some fentanyl, something like that. Alternatively, if it's something that you can do regional anesthesia, it's not uncommon that you'll run them on Sufenta and then block them, and then they're comfortable in recovery. So just be familiar with whatever is going on. Other thing you'll see is that it's run as an infusion, which is probably a little bit more common, generally 0.5 to 1 mic per kilo per hour. The thing you have to think about is your dose and duration. So generally, if you run the patient on Sufenta in that dose range, and it's less than 2 hours, from the time you shut it off till they really start breathing, there's going to be about 15 to 30 minutes. If you go longer than that, it extends up from like 30 to 60 minutes. So you're going to have to plan your emergence a little bit better. You can also do other things to cover yourself during this period. Some people will turn on volatile agents for that part, turn on some nitrous, something like that. Because you have to plan things out, and it can be hard for you. You know, all of a sudden, the med student you thought was going to be taking forever to closes really quickly. So what should have been an hour closure is now 30 minutes, but you've still got Sufenta sticking around or propofol or something like that. Again, this is something you're going to mix your own infusions. Usually we reconstitute to 50 mics per ml. It is nice because you have cardiovascular stability. And as I said, a lot of times we'll use it as an infusion. So things for you to think about when you're looking at narcotic infusions. Sufenta sticks around a lot longer than Remy does. So if it's something you're going to need a quicker wake up or maybe a little bit less predictability, you may use Remy fentanyl instead of Su. The thing you have to worry about with Remy is it's significantly more expensive. All right, so moving on to Remy. Again, you can use this as a loading dose medication, but it's most commonly going to be used as an infusion. I've seen it used, and I've used it a couple times in the place of succinylcholine, because if you give a higher dose for induction, you can achieve skeletal muscle paralysis very quickly. The nice part about that is it goes away very quickly. So if it's somebody that maybe succinylcholine is contraindicated for some reason, but you still want to intubate them, you could consider doing it with propofol. But if it's somebody that is maybe not stable enough for propofol or something like that, you may consider using remifentanil for that as well. Ultra short acting, it's metabolized by plasma esterases. You'll probably see that again. If you give it, especially in high doses, you get quick respiratory depression. You can also have bradycardia. So if you've got somebody that you're going to consider dosing it for intubation in place of succinylcholine, I would consider giving them glycopyrrolate. Pretty significant reduction of MAC if you're using it as a drip. Commonly what we'll do is use remifentanil and propofol together, but it depends on where you go and kind of the practice there. And then as far as what cases, anything they're doing nerve monitoring, so neuro stuff, carotid endarterectomies, some cranies, and then sometimes they'll use it for eye stuff too. It's just kind of expensive for eyes. The other thing for you to think about is that it is going to go away quickly. So on the back end, you're going to need something to cover for pain. Looking at PO stuff, there's quite a bit of variety there. If you go back to the pain lecture, you'll see kind of some of the preferred means. But what we're seeing with a lot of patients now is that we're giving like oxycodone or up front as part of our PO pre-medication, and then we wind up not having to give a whole lot of IV stuff. And likewise, instead of giving a kind of a true opioid or true morphine agent, we're giving Tramadol on the back end, and that seems to be covering patients pretty well. Codeine is a very poor pain medication. It's almost like Demerol, where you get more high than you do actually pain relief. The other thing you have to worry about with codeine is it's got a lot of active metabolites. So you may see that the patients continue to have sedation. It's for a long time we were heavily for pediatrics, or you'll see like Tylenol with codeine cough syrup, but that's kind of fallen out of favor after some adverse events. The other thing you'll see is that there's a decent number of medications that are agonist and antagonist. So you may see those used in situations where you want to eliminate some pain, but maybe avoid giving a full agonist. So the big one with that is going to be Nubain or Stadol, but it kind of varies. The other thing you'll see is that they're being used for patients that are coming off of opioid addiction. So those patients we used to put on methadone for a long time. Now we're using more buprenorphine or Suboxone. So just be familiar with your patients. The other thing you'll see is that you may be able to treat some of the issues the patient's having, whether it's itching, respiratory depression, without fully reversing their analgesia. So if I have somebody that's itching or having respiratory depression and I give them Narcan, now I've blocked their receptors, so they're not going to be able to get any pain medication. I'm going to have to overcome that. So one of these agonist antagonists may be beneficial for them. All right. Do you guys have any questions real quick? All right. So Jay had asked about, is Demerol more indicated when your patient is shivering without being reported cold? Yeah, you'll see a lot of patients, in spite of the fact that they are perfectly normothermic, will shiver postoperatively. It's not uncommon. So those are the patients you're usually going to use Demerol for. You'll also see people that, in spite of everything you can do, that they're still a little bit cold. So you may consider giving them some Demerol as well, just for their comfort. What medication were you talking about, Amy? Were you talking about Paralytics? I assume so. Oh, Sufenta. 20 mics per kilo for a Sufenta induction would be pretty high. A lot of times you'll see it given closer to 0.5 to 1 mic per kilo. I've never seen anybody give that much Sufenta. Usually when I draw it up and give it, I don't give any more than 20 mics for induction. So I would be surprised if somebody was giving that high. I almost wonder if that wasn't supposed to be like 1.89 or something, because that's an extremely high dose. I would know the 0.5 to 1. Indigo had asked about giving. Uh-oh. Sorry, I think my internet dropped there. So it's kind of hard to predict who's going to be high risk for shivering. I will commonly utilize Precedex for all my cases, so I don't have a whole lot of shivering issues. But you will see sometimes that people will try to use Precedex for recovery. Oh, I'm sorry, you had a headache. Post-dural puncture headaches are miserable, and sadly, anesthesia providers, especially some that's been go to other programs, tend to blow off headaches. I agree. There's not a whole lot of difference between 18.9 and 20. I would go with easy math. Yeah, I don't know why they came up with that. And as far as, yes, if they've shivered before it, that would probably increase their risk. Yeah, that's crazy. Thanks for sharing that, Daryl. The times I've used Sufenta as a standalone agent, I've never given anywhere near that much. Maybe that was their experience with things. So you'll see there's a lot of variation depending on where you go and as far as what people use. But that's a pretty extreme dose. I wouldn't give that much, but if that's what Stolting says, so be it. The other thing you'll see is that there's quite a bit of variability here from one medication to the next. So there's not a magic answer. It's generally going to be more of who you work with that day and what their answer is. So don't get hung up on one thing versus another being correct. Now you'll see some of those things kind of are more fringes. Like I was talking about using remifentanil in place of succinylcholine. That's something you can do, but it's not something that's really common. So it's kind of the same thing with sufentanil dosages. You'll see that it's something that can be done, but it's not a real common thing to do. So I wouldn't worry too much about it. As far as testing purposes, there's not going to be anything on that specifically. But, there is some variety there. Sufentanil inductions are not a very traditional thing to do. But, you may go someplace where that's what they do. One of the other things I didn't even mention because it's not so common, alfentanil. Some places you will go and use alfentanil as well. I haven't seen alfentanil in 10 years, but there are places where they use it, so don't be surprised. So I was just looking up some other stuff. Kind of the guideline I found, if you're using opioid only for sufentanil, is 10 to 30 mics per kilo. So I'm not sure how they came up with this specific 18.9. So I think 10 would be a good number to remember. And then the other thing you're going to see, we can give you numbers for all these patients, but everything's going to need to be adjusted depending on that patient. I tell you 2 milligrams per kilogram, and then you've got an 85-year-old. They're probably going to need a substantially reduced dosage. Yeah, if you give too much fentanyl, you can always just support the respiratory effort for a while. One other thing I will throw in there for you, remember pain is not fatal. So if you're in doubt or you have somebody that's unstable, you can always give opioids later. If they demonstrate that they're in pain or their blood pressure will tolerate it, you can move on to the opioids then. You don't have to front load for everything. All right, so moving on to opioid antagonists. The most common one we use is naloxone or Narcan. And generally when we give it, it's going to be in a very low dosage. It's usually supplied to us 400 micrograms or 0.4 milligrams in a 1 ml vial. And we usually dilute that to 10 mLs. So you've got 40 mics per ml. If you've ever given Narcan in the ER or like EMS, usually in that setting you gave, 2 milligrams, 4 milligrams, something like that. You'll see for our patients, we're trying to avoid some of the side effects that you get with those higher doses. One of the biggest things is just being angry and violent when they come back from whatever you just did to them. So we'll usually titrate it to the respiratory rate. So I may give 40 mics, wait a minute, give another 40 mics. Other things you'll see, just because of that abrupt reversal of analgesia, they become angry. You may have a pretty high sympathetic drive all of a sudden. And there's a potential for flash pulmonary edema in those patients. The other thing you'll see is give it for, and I generally prefer to give a mixed agonist-antagonist. It's for some of those opioid-related side effects, so urinary retention, muscle rigidity, sphincter voti spasm, some of those things. I will give a mixed antagonist if I can. The other thing you got to keep in mind is depending on what medication they've gotten or taken, that the Narcan can wear off before the narcotic can. So you may have a re-onset of symptoms. Benzodiazepines, we're going to talk a little bit about some of the common ones there. We give them for a variety of reasons. The biggest one we give it for is sedation and anxiolysis. So the other part of that is if you have somebody that's not anxious, you don't have to give medications for it. There are a lot of patients that I will forego the Versed up front because they're calm. And if you think back to when you were doing your induction stuff in SimLab, every patient doesn't necessarily need 1 to 2 milligrams of Versed. On the other hand, you may have patients that need more. If you've got a long-term alcoholic or somebody that's already very agitated, they may need a higher dosage than that. Nice things about it, one of the biggest reasons that we give it outside the sedation and anxiolysis is for amnesia. It's almost kind of like our whoopee or our comfort blanket. You give them some Versed in hopes that if for some reason they're light, they may not remember what's going on. You will have some people that insist they get it for that reason. I think it's probably poor planning that you're counting on a milligram or two of Versed to save you from a poor anesthetic. But you will see people that insist on that. Other things, it is an anticonvulsant, so if you have somebody that's high risk or has a seizure history, it may be beneficial for them. And you do get a little bit of skeletal muscle relaxation with it, especially when you move to higher dosages. So as far as the potency, Ativan tends to be the most potent, followed by midazolam and diazepam. We don't give a whole lot of diazepam for anything anymore, but you will see patients that come in from home on it. So from a cardiovascular standpoint, you generally have minimal effects with sedative doses. The exception to that is if you have somebody that's got like bad aortic stenosis or is sick. And when I say sick, I usually mean like poor cardiopulmonary status. Somebody like that, a milligram of Versed may be enough to kind of tip them over the edge. I know of a couple patients in the last year that got a little bit too much Versed and either arrested on induction or pretty quickly thereafter. So don't assume that it's an innocuous medication. The other thing you'll see is because they do get their hypoxic drive to breathe depressed by it, you may not be able to pre-oxygenate. You'll see that, especially as a student, pre-oxygenation is your friend. So I call that kind of your time. The better you do pre-oxygenating your patient, the longer till people start getting antsy and you get hip checked out of the way if you're struggling with an airway. So if you don't need Versed, don't give it. Or consider getting him in the room and getting him pre-oxygenated and then giving the second milligram or something like that. Again, it's kind of going to depend on who you work with that day. You do get a little bit of the dose-dependent respiratory depression. It's not necessarily just, you got Versed and now you can't breathe. Higher doses obviously make it a little bit harder to breathe. Thing to remember, no matter what the dosage you give is, any patient can have apnea with midazolam. So if you give it, make sure you monitor them. Some places the holding nurses will give it. You'll write an order for it and they'll give it. Make sure somebody's monitoring that patient. The other thing I tend to do is if I can, I will put a pulse ox on the patient and see what their room air saturation is before they get any medications. Because if you do have that patient that gets Versed and maybe they're not breathing quite as well as they were, see where they were to start off with. You might be surprised how much a milligram or two of Versed will decrease your respiratory effort. Other thing to keep in mind is you do get a synergistic effect with almost everything else we give, especially opioids. But most of the time, that's something we want, so don't be surprised. The nice thing is we do have a reversal agent for it. You can always give Ramazcon if need be. But the other thing to think about is, what's the big things we're worried about? Respiratory depression being one of them. As you guys mentioned earlier, it's not a big deal. I can just ventilate them or intubate them and get them through it. Or maybe that's what I wanted. It may happen a little bit faster than I intended, but it's generally not a bad thing. What you will see in some patients, though, is you finish the case, you've blown off all your gases, maybe they didn't get any fentanyl or, pupils look like they're not constricted at all. So you're thinking it's not a respiratory thing, but they got 5 of Versed or something like that. You may need to consider reversing the benzos at that point because that could be the one thing that's really impacting your patient's respiratory effort and CNS effort. So that's something for you to think about, but it's not very common. All right, let's see. Any questions on that? Yeah, Gerald mentioned that the low HCAP score might be fatal. You'll see that, unfortunately, he's more right than I would wish. But we can always give them pain medication on the back end. As far as your induction goes, make them demonstrate the need for it a lot of times before you give it if they're sick. If they're healthy, go down your traditional route of giving everything up front. But if they're not healthy, you might want to wait and see. I've seen several patients where somebody gave 100 mics of fentanyl up front, which seems like a really low dose in a normal person. But they wound up fighting the blood pressure, for 15, 20 minutes thereafter. Whereas if they'd avoided that, they might have been better off. All right, so touching on nausea and vomiting agents, the 2 most common ones that you're going to see given are going to be dexamethasone and Zofran, but there's a wide variety of agents out there. If you have somebody that's got a strong history of PONV or is high risk for PONV, I would encourage you to hit multiple receptors and kind of think about what medications you can give and also what you can avoid for that patient. If I have somebody that's high risk for PONV, I may consider doing a TIVA and avoiding opioids altogether. But you've got to stop and look at your patient and what you're doing and that sort of thing. So I'm just going to run through these a little bit quick because there's a lot of them. Decadron, the big reasons we're going to give it is for anti-nausea, anti-inflammatory, and it's long-acting. As far as the dosage goes, generally it's going to be 4 to 12 milligrams. You'll see that for some of the bigger cases like neurosurgical stuff or I give everybody at least 4 milligrams. Same thing with Zofran. I usually give it up front. I'll give my Decadron and Zofran at the beginning of the case. There's a wide variety of literature out there that kind of argues about what the effective timing for Zofran is. Some places say you need to give it up front. Some places you need to give it on the back end. If I have somebody that's high risk for PONV, a lot of times I'll give a second dose. I'll give 4 milligrams of Zofran and 4 of Decadron up front, and then chase it on the back end of the case with another 4. If you look at patients that are receiving chemotherapy, they commonly will get very high doses of Decadron and Zofran. So don't be afraid to administer the medication just because you've already given some. For the most part, they're pretty innocuous. The one caveat to that is if you have somebody, especially a brittle diabetic, you may want to not go real high on your Decadron dosing because it is going to cause their sugars to go through the ceiling. Droperidol was really tough to find, and it's now starting to come back into vogue. It's a great antiemetic. It kind of got a bad rap for a while there because of long QT syndrome, which also comes from Zofran. And you can also get a little bit of confusion. So if you've got somebody that's a little bit elderly, you may want to consider avoiding droperidol. It got a black box warning because of that. Zofran actually got a black box warning as well, but we continue to give it. The one thing you will see is I kind of break these patients up into two groups. You have the nauseated, and then you have the already vomiting patients. Zofran works really well on the nauseated end, but if they've already started vomiting, it doesn't work very well. Things that are a little bit more beneficial at that point are something like droperidol, Phenergan, Emend. So, and just kind of depends on the practice where you go again. Reglan, a lot of times if I have somebody that's high risk, I'll go ahead and give some Reglan up front as well. Usually I wait to give it post-induction because you will see some of the strangest anxiety and extrapyramidal side effects from patients getting Reglan, like to the point of a friend gave it one day and his patient wanted to refuse, was like crawling out of the bed. So usually I'll wait till post-induction to give that. But it works pretty well as well. And generally about 10 milligrams of Reglan. Benadryl, as I mentioned earlier, I usually give a little bit lower doses and have good results there. So the most I usually give is 12.5 milligrams. You'll see when you get to the higher doses, 25, 50 milligrams, that you tend to get pretty significant sedation. So that's going to be the patient that sticks around and pack you for a long time. Scopolamine patches, I'm not personally a fan, but they do work. The problem is you've got to think about the timing here. They really need to be on before surgery. So get the patient into holding, and that needs to be one of the first things they get on. If not, they put it on the way to the hospital that morning. You'll see a lot of times that somebody will order it, and they get it as they're rolling back to the operating room, and it's just not very effective. The other thing you'll see is if you've got somebody that's a little bit older or kind of high risk for psych stuff, that it can exacerbate those things. But there are some places they use scopolamine patches for everybody. If you've got somebody that's especially high risk for reflux, Pepcid is pretty common. It not only decreases the acid level, but it also reduces the nausea and vomiting. The FDA approved it for morning sickness. I'm not sure it really helps, but it's one of the few things that's FDA approved for pregnancy. Again, Phenergan, if I'm going to give that, I usually do it as a rescue drug. Same thing as far as like diluting it and giving low doses. Usually I'll give like 6.25 or 12.5 milligrams of Phenergan. But if you have somebody that's really puking or having a rough day, it's not uncommon to go up and give like 25 milligrams. Make sure if you're giving it, you've got a good IV. It's pretty toxic to soft tissue. So some places they dilute it in a 50 ml bag. A lot of times we don't do that in anesthesia. We just make sure we've got a good IV and dilute it. It will burn if you give it straight. So make sure you dilute it to at least 10 or 20 mLs. As I mentioned earlier, propofol works pretty well as an antiemetic, so you can always consider that. Other things to think about is your anesthetic and how you can change it for those patients. And then one other thing you may see that's a little bit newer medication, I've only worked at a couple of hospitals that it was available and it was only for rescue stuff, is Emend. It's a nice antiemetic for high-risk patients. All right. Any questions about PONV medications? I would be surprised if somebody coded on induction because of heparin. That's kind of strange. And my other question is, why were they giving heparin on induction? Maybe I didn't understand that entirely. There's a long list of reasons that people could code on induction, though heparin would be pretty low on my thought process for that. Okay. Yeah, that's kind of strange that, they gave heparin and the patient coded. I think Todd's probably more right. It was a sick patient on dialysis, and there's a long list of reasons they could have coded on induction. Heparin would not be one of the choices I would worry about. The doses they're giving to block ports and stuff like that is very low. All right, so moving on to muscle relaxants. They've been around for a long time, and for the most part, they're fairly safe. We're going to talk about the common ones we use and kind of the dosage. But if you happen to be back in the bush and you need to go hunting, using Curare may be a nice resource for you. So the only depolarizing agent we use is succinylcholine. You will see that brought up time and time again. And it's something you have to consider for your anesthetic because of the depolarization. There tends to be a large number of side effects and contraindications associated with it. So the reason we use it, very fast onset, 30 to 60 seconds, if even that long, and it goes away very quickly. So if I need to put an endotracheal tube in somebody, but I want them to be able to breathe, I may use succinylcholine. The other thing is, going back to it, you see this as a culture. It's not uncommon that people will have trained one way, so that's what they do. And what they will do is use succinylcholine for induction, and then for long-term paralysis, switch to a second agent. I generally just use one agent for induction and stick with it throughout the case. With rocuronium and high doses, you can achieve almost the same onset as succinylcholine with all the side effects. So big things to worry about. It's a triggering agent for malignant hypothermia. You have to worry about giving it in burns, although that looks like bums on there. If you have patients that have muscular paralysis, they may be upregulated. Patients with renal failure, classically you see a 0.5 to 1 milliequivalent per liter increase. And we try to avoid sucks for those patients because of the potential for hyperkalemia and arrest. With that being said, it still remains kind of the gold standard for RSI, but I think that's quickly going by the wayside. The other factor in that was that if I had somebody I was not able to secure an airway, with succinylcholine it would go away quickly. With the longer-term agents, I didn't have the ability for the medication to go away quickly. So Gamadex has kind of altered that. If you're someplace that has Gamadex, you can give a very high dose of that and reduce the duration of action pretty significantly. As far as your dosing, you'll see there's quite a bit of variety there, but generally it's going to be 1 to 2 milligrams per kilogram for induction. As far as for treating laryngospasms, usually it's going to be 10 to 20 milligrams total. Usually it's applied 20 milligrams per ml in a 10 ml vial. Another thing for you to think about is it's got to be refrigerated. If it's outside the refrigeration, it's generally only good for 14 to 28 days. So you may see that it's got an expiration sticker on it, and that's why. And we'll take a break after we finish up muscle relaxants. Nimbex or cisatracurium is an isomer of atracurium, and it's a lot more potent. With that being said, it's almost like water instead of a muscle relaxant. You'll see that you give it, and 20 minutes later, your patient's moving again, or you never get very nice muscle relaxation. The nice thing about it, you don't have a histamine release, so it generally doesn't cause any sort of hypotension. It also doesn't tend to accumulate like some of the other muscle relaxants may do. As far as the dosing, usually it's going to be 0.1 milligrams per kilogram if you've already induced with sucks, or if you're just the standalone, 0.2 milligrams per kilogram. Historically, I found that patients don't do very well with Nimbex as an induction agent. It's almost like you're intubating with whatever else you gain. So sometimes if I'm in a situation where I have to use Nimbex, I'll topicalize, I'll give other things. The other thing you may see is a Nimbex infusion. When we first started doing like therapeutic hypothermia, we were doing a lot of Nimbex infusions because we were worried that it would stick around if we used something else. Again, Nimbex is refrigerated, as is rocuronium. It sucks, but it's, a lot of times it's been taken out of the fridge and it has a limited duration of use after that. It's your muscle relaxant of choice for renal failure because of its metabolism, so you don't have to worry about some of the bad things that happen, and it also will go away quickly as opposed to some of the others that are dependent on kidney function for elimination. Again, it's expensive, and like I said, it just doesn't work very well as far as muscle relaxants go. Vecuronium or Norcuron, induction dose is 0.1 milligram per kilogram. Again, if you're using it post-sux for long-term paralysis, cut your dose in half. You can also use it as an infusion, but you have to worry about it accumulating. One thing that's a little bit different with vecuronium, it comes as a powder and you have to reconstitute it. So generally when you reconstitute it, you're going to reconstitute to 10 milligrams per ml. So there's 10 milligrams in the vial. You'll just add 10 mLs of sterile water, saline, whatever, and reconstitute it. One of the issues you run into is it tends to have active metabolites. So if you've got somebody that's got renal failure, you may see that it sticks around a little bit longer. As far as duration of action with VEC, it's pretty reliable, and you'll see some people tend to use that over rocuronium for that reason. You generally get about 30 to 45 minutes with a full-strength induction dose of VEC. Rocuronium is kind of the newest muscle relaxant we're using. As far as your traditional induction dose, it's 0.6 milligrams per kilogram. So when you start looking at this, you'll see that anesthesia providers commonly give, dose XYZ every time. The patient may require 50 milligrams, but they give 30 milligrams instead. And what you see is that those patients may get a little bit less duration of action out of that, but it's not commonly a problem. Or they may go to the other extreme where they give 50 milligrams to everybody because that's what they usually do. So again, you'll see some variability there. And it comes with a dosing range. If you give that 0.6 milligram per kilogram, generally it takes about 2 minutes to set up. If you give the RSI dose, it's a little bit faster, 30 seconds to a minute. So if you're falling somewhere in that 0.6 to 1.2 range, it's okay. You just know that you're going to have a little bit faster onset in that time period. You can also use it as an infusion, though it's a little bit less common, and it tends to result in less issues than long-term administration of vecuronium. It's applied 10 milligrams per ml, usually in a 5 or a 10 ml vial. The nice thing is you don't have a whole lot of the metabolites that you run into with vecuronium or something like that. It's generally not affected by renal failure, and you may see a little bit of prolonged duration if they have liver failure, but it's not quite the big warning. Again, just like any of the other muscle relaxants, you may have a risk of prolonged action in the elderly or in pregnancy, and there is a potential for respiratory issues post-procedure. So the big part of that is just to make sure your patient is fully reversed before you take them to PACU. All right, so reversal of paralytics, we'll get into that in just a minute. I'll take a look at questions. We're still worried about heparin. You guys will see, you're going to give huge doses of heparin, like 30 to 50,000 units, and nothing bad happens. So the little bit that's packed in that port doesn't seem like it would be the issue. Without being there, it's hard to say, but I suspect it was somebody that was unhealthy to start off with, and induction just wasn't good for him. Jeff asked about a defasciculating dose of rock before sex to prevent myalgias. It's a pretty common practice to give either a defisculating dose of sucks, so like a 1/10 dose of sucks. So, if my induction dose is 200 milligrams, I would give 20. You can give that up front to help prevent myalgias, or give some rock. And generally, I do 0.5 milligrams per kilogram just because the math's a little bit easier. But I also avoid sucks for a lot of patients because I use rock instead. But it is fairly common to give something. But you'll see, especially when people are newer, starting out, and they're using sucks, that the fasciculation is almost like a comfort for them because they know their sucks is working. Other things, and I would have to pull up the exact research, but I think there's some decent evidence out there that defasciculating doses don't actually prevent myalgias. But I've read varied studies on that. I know it's common practice to try and administer medications to prevent it, but I think it actually doesn't work. Megan asked if you adjust VEC doses in females. I've never heard that it's entirely possible, but I would have to, again, look to see what the current research is. All right, it's 10:06. Come back at 10:11. All right, getting back to paralytics, we're going to talk about the reversal. And there's kind of some varied thought processes on this. You will see some people keep patients paralyzed for a long time. Some people only paralyze patients to get their ET tube in. So there's quite a bit of variety there. And it's good to learn all the different approaches because you never know when you're going to have to use a different one. The other thing you will see is some people redose their paralytics, other people don't. So the actual level of paralysis you see in these patients varies quite a bit. Some people will keep their patients fully paralyzed to the last minute, especially now that Sigamadex is available a lot of places. Other places, like I said, they just use it for putting the tube in and then move on. So first of all, if you use a depolarizing agent, you don't have to reverse it because it goes away so quickly. So we only reverse the non-depolarizing agents. And there's a variety of medications we can use for that. The most common one used is neostigmine, even in pediatric patients. You will see with the strange, pharmaceutical situation we're in, that patients may be on a variety of medications that interact. One of the big ones is physostigmine. We had a student about 5 years ago that wanted to use physostigmine to reverse his patient because he'd never done it. And even though it's called antilirium, it's pretty common to have delirium and some strange behavior when they woke up. So he used it one time, figured out why we don't do it, and stopped using it after that. Other common medications that you may see, edrophonium is used in pediatric patients, but it's not quite as common as neostigmine. And I've never used pyridostigmine at all. So take that with a grain of salt. So as far as the medications go, edrophonium's got a fairly decent onset, a minute or two. You may see that there's some acetylcholine release, and it may reflect a kind of a presynaptic effect. So you may see some almost paralysis type symptoms with giving it. The onset for neostigmine is a little bit longer. And the other thing you have to take into account for all these medications is how significant the neuromuscular blockade is. So a lot of times if I have a patient that got, some sort of paralytic up front for induction and it's been 30, 45 minutes, I've got 4 out of 4 twitches, I'll pretty comfortably go ahead and go with neostigmine. On the other hand, if it's pretty recent since they got a dose, I may consider going with Sigamadex instead, just because I get a little bit better reversal with it. But you've got to look at your patient and everything else. As far as the duration of action, they're all fairly long. So it should be enough, even if you've given something extremely long-lasting like pancuronium, that it's enough to overcome it. As I said, neostigmine is the most common, and it's generally about 40 to 60 minutes. And that's part of the reason we don't use edrophonium is because it goes away pretty quickly. So when you're giving that, one of the issues you run into is that all those medications will cause profound bradycardia. So to counteract that, we generally will give glycopyrrolate with them. And as far as the dosing for that, you will see some variation, but it's usually 0.05 to 0.07 milligrams per kilogram. So, strike that. The neostigmine dosing is 0.05 to 0.07 milligrams per kilogram. So you'll figure out your dosage for that patient, and then you will match that usually 1-to-1 with your glycopyrrolate. So if I figure out that I'm giving a patient 5 milligrams of neostigmine, which is 5 mLs, I will then give them 5 mLs of glycopyrrolate, which would be 1 milligram. So they would get 5 milligrams of neostigmine and 1 milligram of glycopyrrolate. With that being said, a lot of times to prevent tachycardia, I will cut the dosage of my glycopyrrolate. So I would give 5 milligrams of neostigmine and 0.8 milligrams of glycopyrrolate. And it's enough that I don't have bradycardia from the neostigmine, but it's also not so much that I don't have tachycardia from the glycopyrrolate. And usually, if you've given glycopyrrolate throughout the case, you'll still go ahead and give the dose that you would to counteract the use of neostigmine. And other things for you to think about, there are some side effects from giving the glycopyrrolate. Obviously, the tachycardia I mentioned. Bronchodilation is generally a good thing. You'll see the drying effects. And one thing for you to think about is that when you start looking at the medications, other things you can use in similar situations, atropine, but because we tend to get a lot more tachycardia with the atropine, we try and use glycopyrrolate first. I touched on Sagamodex. This is the newer medication that's come out. It's kind of cool. It works a little bit differently because as opposed to the other ones, this actually essentially encapsulates the neuromuscular blockers. And you don't have to give it with any of the agents to prevent bradycardia because you're not giving the neostigmine, so that's kind of nice as well. There are risks that go with it. One of the biggest things is there's been some reports of bradycardia and asystole. Personally, I've never experienced it, but I think part of that has to do with the dosage that's given as well as how fast it's given. So when you start looking at giving Sagamodex, it's not quite as easy as the dosing for neostigmine or glycopyrrolate. You have to evaluate what level of blockade you have, which makes sense. We were essentially doing that with neostigmine and glycopyrrolate, but we were still giving the same dosage. What you'll see with the Sagamodex is if you have somebody that's not very heavily blockaded, you may be able to reverse them with 2 milligrams per kilogram. On the other hand, if they still have a heavy blockade, you'd go to 4 milligrams per kilogram. And in that situation that I was talking about where you gave that RSI dose of rocuronium, you could give 16 milligrams per kilogram of Sagamodex. So there's some factors that come into play here. Generally, it's supplied as 200 milligrams and 2 mLs. So you'll see that almost everybody gives 200 milligrams because that's what's in the vial. But know what your actual weight-based dose is, so 2 milligrams per kilogram, or 4 milligrams if there's a heavy blockade. Again, you can always give more. So if you give 2 milligrams and you have great reversal, you don't need to give 4. But you may see that you give 2 milligrams and your patient's still a little weak, a little floppy, and consider giving more. Logistically, if you're having to give that 16 milligram per kilogram dose, make sure you have it available. You may not have 8 vials of Sagamodex in your drawer, so if you're giving RSI doses of rocuronium, you might want to think about making sure you've got enough there beforehand. It's expensive, but it's not as expensive as some of the other medications, and it's certainly not more expensive than a lawsuit for respiratory failure or something like that. So if you have it available, great. Some places it's strictly limited to being used as a rescue agent. Other places you go and they use it to reverse everything. So there's quite a bit of variability there. So let's run through kind of the usual anesthetic plan. And this is the same thing you did with your induction sequence, but you'll see, as we talked about, there's a little bit of variability there. So usually it's going to be Versed and pre-op or rolling back to the room, 1 to 2 milligrams if you're giving it. As I said, some places may give higher dosages, but be cautious doing that. Lidocaine, in your induction sequence, you learned that the 100 milligrams was the max dose. Generally, you're going to see that it's the max dose because it's 1 vial, but your dosing is going to be 1 to 1.5 milligrams. Some people will give less than that. Some people will give more, but it's more common for them just to get 80 to 100 milligrams. Fentanyl, we're going to administer that earlier on in the induction sequence if the patient's stable for it. Remember, it's not just for pain. It's also to help block the sympathetic stimulation from laryngoscopy. So you want to give it a couple minutes before you stick that blade in there for that purpose. If you're giving it for pain, you could give it whenever you wanted. But it takes a minute or two for it to work. So if you give it as you're putting that blade in, it's not going to help you out at all, and you'll see some tachycardia. Alternatively, we'll see some people that if they're not giving opioids or doing low opioid stuff, they may use esmolol for the same purpose. So then we're going to give an induction agent, propofol, etomidate, or ketamine. Think about the settings that I gave you for each of those, propofol obviously being the most common, and then figure out what you're going to do for your maintenance phase, whether it's going to be some sort of TIVA, your volatile agents. Make sure you know the doses for each of those. I'm harping on this because a decent number of you at your clinical orientation are going to have to go in and sit down and take a quiz, and they're just going to ask you the doses for these medications. So if you don't know the medications, they're probably going to tell you need to go home and figure it out, which is reasonable. I wouldn't let you give a medication you didn't know what you were giving and how much. Paralytics will follow that. So one thing I didn't really talk about was pancuronium because it's kind of hard to find now. I haven't been able to find it for over a year. And it's essentially similar to vecuronium, longer duration of action though. And the other thing you see is that it tends to cause a little bit of sympathetic stimulation. So if you have somebody that's hypotensive, post succinylcholine, you may consider pancuronium as your maintenance agent because it'll help keep your blood pressure up a little bit. Other than that, it's pretty similar, other than the long duration of action. Over time, you're going to titrate in some longer-acting pain medications, Dilaudid, morphine. Other things you can think about, we talked about it during our pain management, magnesium, Presidex, lidocaine infusions, regional blockade. Somewhere in here, you need to work in your antiemetic agents. I know there are places they don't give antiemetics unless the patient has a score demonstrating it. Personally, I think it's pretty low risk, and it's a big dissatisfier for patients if they get to recovery and they're puking. So I give everybody antiemetic agents. I haven't had any problems with that. With that being said, I could go in tomorrow and give somebody some Zofran, and they've got long QT syndrome. The next thing you know, they're bradycardic. But generally, the more common issue is that you're going to have PONV than that. And then finally, on the back end of the case, consider some reversal agents as well. If you've given a non-depolarizing muscle relaxant, you need to give some sort of reversal agent. You will see places where they don't reverse patients if they've gotten lower doses, if it's been a long time since that. It's kind of like the PONV. It's just not worth it. Having one patient get to recovery and have respiratory depression, remember it, or potentially a hypoxic event, it's just not worth skipping that step. There are lots of different ways to do this. With that being said, when you look, and I gave you a couple medication reference cards, and Dr. Stortran had put one out there too, you will see that there's some variability, even just looking from one textbook to the next. You ask me what the dose of one medication is, I may tell you one thing. You ask somebody else, they'll tell you something different. As long as you're in the ballpark for most of these things, you'll be okay. With that being said, there are some that are pretty common, like the propofol is pretty across the board, 2 milligrams per kilogram. The etomidate is generally 0.3 milligrams per kilogram. Now, when you get to the ketamine, that's when you start having kind of some varied induction doses. So when you're working with somebody or you're preparing for a case, you need to have a dose calculated that falls in the appropriate range for that patient. As I said, as long as you've got some sort of reference to back it up, it will be okay. But you need to be familiar with what that preceptor likes. There are, as I said, a million different ways to do this. So you may work with somebody that uses Brevitol for everything, and it's the only person in your clinical training that ever uses Brevitol. Pass that along to your classmates. Share that information. Don't let them, suffer just because you didn't know something or had to go through something different. That way, they're a little bit better prepared. And likewise, they should be sharing information back with you as well. This is just some of the same things we talked about, and just things for you to think about too. There are a lot of different ways to perform an anesthetic. Almost everything can be done as a regional or a general, depending on the patient. We talked about lidocaine and magnesium for pain relief. Is this something that we could do a block for as opposed to doing in general, and what factors would go into that? Somebody I may routinely do a general on if they're 85 years old and halfway dead, I may consider doing a regional on it. Likewise, if you've got a lower extremity or abdominal procedure, you can consider a spinal or an epidural. And what patients would you want to do that on? The other thing that comes into play is the surgeon's role in that. Some surgeons are insistent on anesthesia being done X, Y, and Z because or somebody read a study somewhere, listened to a podcast, so this is the greatest thing ever. Make sure you have a conversation with them about those things and figure out, as a long-standing practice, what's most beneficial for the patient. We could talk about this for days. The biggest thing is that you guys sit down, look at those cards, know those medications. When you get to your pharmacology test, it's going to be pretty straightforward dosages. But it's going to be medications you're going to have to use every day, so you're going to need to be able to figure out the dosage for that patient. I'll give you a patient weight in the medication. You'll just need to figure out, given the scenario, what you're going to give. It's pretty straightforward as far as that goes. But as I said, this is one of those common areas of concern. Other things we didn't really talk about today, your vasoactive medications. Make sure you know your dosages for neosynephrine, ephedrine, epinephrine, how to mix epinephrine and norepinephrine infusions. Likewise, you need to be familiar with labetalol, esmolol, those medications, metoprolol, and why you would use one versus another, because those are going to be common medications for you to use. So you need to be pretty comfortable with how and when you would administer what. Indigo asked who's writing the questions. I'm writing the questions for the exam. Most of them are already written. I'm just going to add in a couple more. I was going to see what questions and concerns you guys had today before I finished it up. Probably be about 35 to 40 questions. All right, so that's what I have. What questions do you guys have? Amy asked, the list Dr. Stortran gave you in the PowerPoint for this exam. Yeah, it's going to be those things. The PowerPoint for this exam, the list Dr. Stortran gave you, and the pocket cards that are provided there. If you look on the Blackboard stuff, there's two there. One of the other ones, and I'm going to run through it real quick with you guys. I couldn't get it to pop up the way I wanted it to. So this is from Hopkins, and there's a whole lot of different things on here. Part of it's medication stuff, but part of it's just stuff that'll be helpful for you every day. This is the first part is looking at preoperative evaluation of patients. So based off a condition X, Y, and Z, it just kind of shows you common things you should include as part of your workups. So if you've got these issues, consider getting an EKG, a chest X-ray, lab work, that sort of thing. That's a good reference for you. It's not a be-all, end-all. And the other part of that is that you'll see some of this is outside of your control. Patients may have been worked up beforehand. They may not do things as a practice there, but it's just kind of a good reference for you when you start looking at preparing your patients. Your ASA status stuff, predictors of difficult airway, your Mallampattis. The RCRI is how they evaluate the patient's risk for a cardiac event during anesthesia. They use SOPM as their setup as opposed to Samtide. That's perfectly fine. There's some pocket medication doses down here. One of the nice things about this is it not only has the doses for the medications, but it also has indications and contraindications and just some general comments for it. So again, you'll see that there's some variation there from one to the next. The reason I wanted you to have this one is it's just something you can save on your phone as a PDF. And that way, if you have questions about medications or you're having a brain fart or you haven't done something in a little while, you can just flip back to it and take a look. It also has the vasodilators and vasopressors on here. So that's one of the big things I was saying you've got to make sure you know. Not only your push medications like esmolol and labetalol and hydralazine, but also the infusions. You need to make sure you're familiar with the doses, how they all specifically work, patients you would want to use them on, patients you would avoid using them on. Why would you use hydralazine versus one of the beta blockers? Anybody know? Anybody still awake? Yeah, Trent's exactly right. Heart rate. So if you have somebody that's hypertensive and bradycardic, hydralazine is going to be a better choice for you than labetalol or low pressure. The thing you have to keep in mind with hydralazine is that the onset is a little bit slower, so don't get in a rush to redose it. Same thing with your vasopressors. Phenylephrine and ephedrine are the two most common ones that we use, but make sure you're familiar with the infusions as well. And then your local anesthetics. There's a lot of anesthetics out there. Across the board, the most common ones we use are lidocaine, Marcaine, and ropivacaine. So I'm not saying you don't need to know all of them, but if you were going to pick three to know everything about, those are the three I would know. Whether we're doing regional anesthesia, spinals, epidurals, those are the common ones we use. So be familiar with those. And then they've just got some reference stuff as far as airway things. Extubation criteria, this probably is a good thing. Troubleshooting arterial lines, some help you out with ventilator stuff, normal age-based vital signs, especially when you start getting to pediatric patients, those can be problematic for you. So if you're going to save something on your phone, that might be a good one to kind of save in there. All right. So when I need to look up a drug, it kind of depends on what's going on. I am not providing any sort of commercial endorsement for this, but there's a couple apps out there that I use. One of them is called Gas Guide, and it's got a whole lot of different stuff on there. So it's got procedures, medications, that sort of thing. So that's kind of helpful for you if you need that. Other ones that are helpful for pediatric patients, you're going to find that they're one of your bigger frustrations for your medications. Someplace you're going to go and you're going to have to do it in your head, but there's a app called PD Anesthesia that I use. You could certainly consider using Vargo. I haven't looked at it in a while, but I'm sure it's got a lot of that stuff on there too. So just figure out what works for you as far as those programs and what platform you have. Other questions? Yes, you need to know your uppers and downers, so your vasopressors as well as your vasodilators and your different cardioactive medications. Yes, there will be a calculator. No, I have not been in Tito's backpack, so I'm not sure what's in there. Leonard asked about, should I stop listening to that Head of the Bed podcast? There's a lot of different thoughts out there. Anybody's thought is not necessarily bad, even if you disagree with it. It may be something they say there that makes you start thinking about things. So listen to everything. And what you're going to figure out as you go through your anesthesia career is you take away things from everybody you work with. It may be a new idea that you want to go try out. It may be something that somebody insists on doing that you figure out is a horrible idea and you never want to do that again. But you're still taking something away from it. And part of it's just going to come down to your judgment and experience as far as whether you like that idea, don't like that idea. This is the greatest thing ever. This is horrible. So kind of stop and evaluate all those things on your own. You're smart people. Stop and look at it. As I said, probably 35 to 40 examination questions. I'm looking at the list Dr. Stortran sent you guys. Other things I would add to that list, Precedex, ketamine. Other than that, I think it's pretty inclusive. Those are the only other two I would consider adding to it. Let me check on class Thursday. I assume so. I wasn't actually supposed to be teaching today. Dr. Stortran was. So let me look and see. I assume I have control over things. I don't get donuts anyways. My kids eat them all. They would wear you out, Indigo. I don't see that you have class Thursday. I'm sorry for not having a definitive answer. As somebody suggested, I would make sure you study. This is really one of those things you've got to know. I can't stress that enough to you. But I'll ask Dr. Stortran and see if you have class Thursday. Otherwise, enjoy your last bit of freedom. Clinicals are going to be fun. I'm actually out doing site visits this week. There's lots of places that are very excited about having you guys come. They've missed having lots of students. Yes, there will be dosage calculations. Yes, I will provide you with a calculator. As far as dosage calculations, it's going to be something like you've got a patient that weighs 100 pounds. You intend to administer etomidate. What would be your induction dose? It'll be a pretty straightforward stuff like that. I'm not going to try and trick you or anything like that. No, there will not be ideal body weight calculations. And you're going to see, like I said, a lot of times we don't dose medications on ideal body weight anyways, and it comes down to guessing. You figure out your calculated dose is one thing, and then because of factor X, Y, and Z, you need to reduce or increase. No, you don't need to know how to reconstitute things, but you don't for the test, you do for life. With that being said, like I mentioned, there's quite a bit of variety in how you reconstitute things. Some places, I talked about ketamine. Phenylephrine is another one. Some places you mix your own. Some places it comes in pre-filled syringes. You may reconstitute it to 40 micrograms per ml, 50, 80, 100. Just make sure you know the answer as far as, what you have reconstituted before you start giving it. I'm waiting to see. I texted Nate to see if you guys are going to have class on Thursday. Can't have jerky dogs. Any other questions about anything? Everybody ready for Christmas? Your last glimmer of freedom before clinicals? All right. Dr. Stortran said no class on Thursday, so take your time and study. So that's all I have if you guys don't have any questions. Daryl asked about any advice before you head into the abyss. First thing, take a break, relax. Second thing is just be prepared. Everybody's been in this situation, but when you show up to clinicals on day one, there are expectations. A big part of it is this medication stuff. Another one is showing up and working hard. Be there early, stay there late. Like I told you guys from day one, you want to try to see, do, and experience as many things as possible while you're in residency. So the first time you see it is not when you're on your own. Your attitude and your preparation will go a long way. I was talking to a hospital yesterday, and that was one of the biggest problems they had was people showing up, sitting in the lounge, not being proactive. Maybe their case was delayed. Instead of trying to find something else to do, they were just sitting around. It just looks poor. While you're there, get as much experience as you can, and you're not going to get it sitting in the lounge. And the other part of that is every day is a job interview, even if you don't intend to go work there, because people talk to each other. So you may be that one student that was always hanging out in the lounge, and that's what they remember. It's not the 5 million awesome things you did. The other thing you will see is even though clinically you may be awesome, your behavior and your personality can be extremely problematic for you. So, you show up late, you disappear, you're not prepared. Even if when you start doing stuff, you do great, they're going to remember the issues you had. That was the girl that wasn't ready for cases, the girl you asked questions and she didn't know what was going on. A lot of those sorts of things. So not only prepare yourself, but share your preparation with your clinical sites. The other students at your clinical sites. If you work with Brian one day and Brian pimps you on question X, Y, and Z, I'm not saying you have to give him the answers, but tell him to be prepared for this, that, and the other. Likewise, share the things that they prefer, don't like. Everybody's got their little OCD triggers and that sort of thing. Feel free to go ahead and share those with each other. I'll tell you right now, when you come to JPS, I send you a text message that tells you what I like and don't like. So there you go. And you'll see when you go through kind of your clinical progression, the first 8 months to a year, you're still kind of finding your way. You're figuring out all those things you like and don't like. After that, we kind of let you do your own thing. As long as it's not dangerous to the patient, you've started to formulate what you like in anesthesia and what you don't like. So we try and stay out of your way for the most part. There's always going to be people that you have to do it my way because, that's what I'm comfortable with. And then you're going to have other people that say they don't care what you do as long as it's not dangerous to the patient. So just figure out the variety of things there. Chitty asked, what would you suggest? And the biggest thing is just come in with a good attitude and work hard. Show up early, stay late, make sure you're prepared for things. You don't have to run around and kiss everybody's ass, but at the same time, be respectful. These people are volunteering their time to help you be a better person and enter this profession. So just be respectful of that, just like you would for anybody else. And that's the biggest things I've got.